Okay, Adrian, I think we'll go ahead and get started.
Okay, I'll give you a quick introduction. Thank you everyone for joining us. This is a continuing education provided by Nashville Veterinary Specialists. And this is going to be on valvular disease in dogs, and it's provided by Dr. Kiira Rodriguez. Dr. Kiira Rodriguez is a board certified veterinary cardiology by the American College of Veterinary Internal Medicine. She graduated in 2014 from the University of Illinois College of Veterinary Medicine. She then completed a one-year rotating internship in small animal medicine and surgery at Michigan State University, followed by a 3-year residency in cardiology at the University of Tennessee in Knoxville. Dr. Rodriguez has 2 children and 3 rescued King Charles Cavalier Spaniels, which you're going to hear much about in this presentation.
Big for heart disease.
Yeah.
In her free time, she enjoys running, exercise, spending time outdoors with her family, and sampling all the local food in Nashville. Without further ado, I will turn the rest of the presentation over to Dr. Rodriguez.
Thank you. Yes, you'll see lots of my Cavaliers. So thank you for coming tonight. I'll be talking about valve disease in dogs. For those of you who do know me, you might remember, I think 4 years ago when I first started at NVS, the very first continuing education I did was on valve disease, but things are always changing. So I thought it was a time to give another update on things that have changed, and they did come up with a new consensus statement since that last talk. So we'll just be updating and reviewing valve disease, which all of you should be very familiar with. So just a disclaimer, like Adrian said, I have 3 very cute Cavaliers. And so instead of filling your presentation with funny pictures and memes to keep everyone entertained, you will just be subjected to a lot of pictures of my own dogs and occasionally pictures of my human children as well. So to start off, I'll just review some background pathophysiology of valve disease, and then we'll talk about diagnosis and staging and treatment. Before we do that, I'm just going to review some terminology. So for the talk, I'll mainly just say valve disease, since it's obviously easier to say than any of these longer terms. But really, any of these terms are fine. You'll probably hear a variety of them depending on where you did your training. And so any of these terms are fine to use. The only one that cardiologists really shy away from using anymore is endocardiosis, mainly just because it gets confused too often with endocarditis or infection of the valves, which is a very different disease process. So valve disease, or whatever you want to call it, is by far the most common acquired cardiovascular disease in dogs. And it's estimated that up to 10% of dogs you see at your primary care hospital, so 10% of your patients, will have heart disease. And of those patients, about 75% of those are made up of valve disease. So very common. In general, it is more prevalent amongst small breed dogs. However, we also very commonly see it in large breed dogs as well. For example, I have several Australian Shepherd patients, Labradors, German Shepherds, Golden Doodles, you name it. And we can even see valve disease in some of the larger breed dogs that we typically have thought of as being more prone to DCM. So I somewhat joke that anytime I have a Doberman patient, if they're over the age of 10 to 12 years old and they have not gotten DCM yet, then they typically get valve disease. So in general, small breed dogs, but don't forget about your larger dogs as well. And overall, the disease is more prevalent in males compared to females, although we definitely see both sexes affected. And when valve disease is present in larger dogs, the disease may progress more quickly. And we also see more myocardial dysfunction or decreased cardiac contractility in the larger breed dogs with valve disease. compared to small dogs usually have completely normal function to even sometimes their heart function is hyperdynamic or they have increased contractility. So valve disease is certainly known to be genetic in some breeds, like you guessed it, Cavaliers. And the current thinking in Cavaliers anyways is that it's inherited as a polygenic threshold trait, with certain things like sex being a modifying factor, since we do see it in males more than females. And in the Cavalier population in the United States, there are reports that up to 90% of Cavaliers will get this disease by the time they're 10 years or older. So I usually tell my owners essentially 100% of Cavaliers in the United States will get this disease. And the sad part is normally we see this disease start around 8 to 10 years, so middle age to older in dogs. But Cavaliers do get or can get an earlier onset disease where it starts even as young as 3 to 5 years of age. And that's sad because if they're getting at 3 to 5 years, then they do typically go into congestive heart failure at a relatively young age just because they're living with the disease for so long. And besides Cavaliers, it's likely genetic in other breeds as well. I probably see more Chihuahuas, I would say, day to day than Cavaliers. I think partly just because a lot of people own Chihuahuas. But we also commonly see it in certain breeds like Maltese, miniature poodles, Bichons, and those kind of breeds. And occasionally you might hear my dogs barking in the background. So typically with valve disease, it is the mitral valve that's most commonly affected. That's why some people call it just mitral valve disease. But there are reports that in up to 30% of cases, they also have tricuspid valve involvement as well. So it's not always just the mitral valve. And even less commonly, we will see the aortic valve involved too, especially if they have underlying systemic hypertension, which can exacerbate aortic regurgitation. The disease itself affects the valve leaflet. So kind of in this picture, you can see how nodular these valve leaflets are. It also affects the chordae tendineae, which you can see right here. And it affects the mitral annulus as well, as it becomes distended and the shape distorts over time. So what happens on a cellular level with valve disease is that there are valve interstitial cells that start producing this glycosaminoglycan substance. And then the fibroblasts in the valve tissue also are transformed and cause the collagen within the valve tissue to become disorganized. And all of that causes expansion of the spongiosa layer of the valve tissue. And over time, that results in nodules and thickening in the region of valve apposition, like you saw on the previous picture. And with progression of the disease, they can form more plaque-like lesions later on. And so these images right here are some immunohistochemistry of valve tissue. It was from a paper that was comparing basically cellular changes in Cavaliers compared to other breeds, and they really found no difference. So on a cellular level, there was no difference between Cavaliers and other breeds. And these slides are showing the kind of brown staining of on these slides are alpha smooth muscle actin positive valve interstitial cells, which is what produces the glycosaminoglycan substance, which is what we refer to as the myxomatous degeneration. So like I said, the disease affects the valve's leaflets and the annulus, but it also affects the chordae. And over time, that degeneration of the chordae can lead to their rupture or tearing. But despite all these changes to the valves themselves, these dogs are actually not at any increased risk for thromboembolic disease or endocarditis. And I think those are two very common misconceptions. But in general, they do not have an increased risk for blood clots. So that seems to really just be a cat thing with heart disease. We certainly see dogs with valve disease that may have other conditions like Cushing's disease or something like that that might put them at high risk for thromboembolic disease, but the heart disease itself does not increase the risk for blood clots. And then again, these dogs thankfully do not have a high risk of getting endocarditis. We see a lot of small old dogs with valve disease that have nasty teeth. And so it's good that they don't, that doesn't put them at high risk for endocarditis. And the lack of risk for endocarditis may in part be due to the fact that there's really no inflammatory cell involvement in the degeneration of the leaflet. So it's a sterile change. And some thoughts are that the degeneration might in part be due to an abnormal number or type of different mitogen receptors, such as serotonin, endothelin, or angiotensin receptors. And they do know, based on research in rats, that serotonin definitely plays a role in transforming those endothelial cells to fibroblasts, which then produce that abnormal matrix. And fun fact, Cavaliers actually have higher serotonin levels than other breeds, which I think is probably why they're so friendly, but also unfortunately maybe one of many reasons why they're predisposed to valve disease. So the valve disease in dogs itself has a pretty long preclinical period. So they start developing cellular changes to their valve tissue, and then over time that causes valvular regurgitation or leakage. But for a while, their heart chambers remain normal in size. Then over time, they develop progressive chamber dilation or enlargement. And oftentimes these dogs still have no clinical symptoms from their disease. Eventually, as it progresses and they develop severe dilation, we say about 25 to 30% of all dogs affected with valve disease will end up experiencing congestive heart failure, which in dogs is typically manifested as pulmonary edema. So that means that there's a lot of dogs with valve disease that may die of completely unrelated reasons and never develop complications from their heart disease. Once they develop congestive heart failure, we typically say the average prognosis is about 12 to 24 months on average, but there are certainly some cases that go longer, up to 33 months, and some dogs that do progress more quickly, and so will have a shorter survival. And as I stated in the previous sign, so a lot of dogs have this disease, have no symptoms at all. One of the most commonly reported symptoms is likely coughing, either from the pulmonary edema itself, if they have congestive heart failure, or it could just be from their cardiomegaly causing compression of their lower airways. I think that's probably one of the biggest complaints I hear often is just their coughing, especially when it wakes the owners up in the middle of the night. We rarely, people report exercise intolerance. I think we probably see it some, but it's hard to tell since they're older dogs. So hard to tell what's age versus their disease. We can also see syncope in these valve disease dogs for a number of reasons. So they can have syncopal episodes when they're going into congestive heart failure. If they ruptured a chordae tendineae, that can cause them to collapse. If they have varying arrhythmias, can cause them to collapse. We can also see just cough-induced syncope. So if they're coughing just from their heart enlargement itself and they get into a coughing fit, that can then induce a syncopal episode. And they can have other concurrent conditions like pulmonary hypertension, which can cause them to have syncope as well. And then lastly, if they're in active congestive heart failure, of course, they will have an increased respiratory rate and effort. So there are some known prognostic factors, although I still always caution owners that the disease progression is still highly variable. So we try to give them an estimate, but we don't have a crystal ball. And so obviously owner compliance and meaning willingness and consistency in giving medications and willingness and consistency in following their recheck recommendations can make a big difference in their outcome. The presence of concurrent severe pulmonary hypertension worsens their prognosis. We commonly see just mild pulmonary hypertension secondary to left-sided heart disease, what we call post-capillary pulmonary hypertension, and that usually doesn't cause them problems, but if they develop severe pulmonary hypertension, that will worsen their prognosis. If they have a ruptured chordae tendineae, especially if that then results in what's called a flail leaflet, those tend to progress more quickly. Basically, at that point, their valves kind of like a wide open floodgate. So there's nothing slowing down the regurgitation at all. If they have concurrent diseases like chronic kidney disease, that can, of course, complicate our ability to treat as needed. Certain arrhythmias, mainly atrial fibrillation, worsens their prognosis. And then lastly, cardiac cachexia, or the loss of lean muscle mass despite adequate caloric intake, worsens their prognosis. So that wraps up just general review of valve disease. So now we'll probably go into what's more interesting, which is the diagnosis, staging, and treatment of the disease. And I forgot to say, if at any time anyone has any questions, feel free to interrupt. If you don't want to speak it out loud, you can put it in the chat, and I'll try to keep an eye on it. So moving on to diagnosis, many cases can likely have a presumptive diagnosis just based on signalment and your physical exam as alone, but then there are ancillary tests that can be done to more definitively diagnose the valve disease, as well as to stage and know if treatment is needed. So again, signalment is typically a middle-aged to older small breed dog, but don't forget about the larger dogs as well. And on your physical exam, the main finding is going to be the presence of a heart murmur, which is going to be systolic if it's from mitral regurgitation. And so here's a VIN link if you ever want to listen to some good murmur sounds for valve regurgitation. They also have other diastolic continuous murmurs as well that are good to listen to. The point of maximum intensity of the murmur, or PMI, or where you hear the murmur the loudest, is typically over the left apex if it's from mitral regurgitation. And then it's important to know that when you're listening to these murmurs, that a soft murmur is usually mild disease, but a loud murmur does not always mean the disease is severe. So in this particular disease, the loudness of the murmur does not correlate to the severity of the disease. Some other things you can hear in auscultation are musical murmur. And so this is still a systolic murmur, but they're called musical because they are very high pitch. And because they're a high pitch, they're typically very loud. So these are the kind of murmurs that owners will say the dog's sitting next to them on the couch and they can hear the murmur. And so instead of a normal like sh, sh, sh sound to the murmur, it's more of a z, z, z. It's a really high pitch, and I absolutely hate making heart sounds. So here's another VIN link that if you want a better example of what that sounds like, you can go on VIN and listen there. Sometimes early on in the disease, we can hear what's called a mid-systolic click. So this is an extra sound in mid-systole that they think is from buckling or prolapse of the mitral valve. And I find this often mistaken for a gallop. So it's an extra heart sound. So there will be 3 heart sounds, which sounds like a gallop, but a gallop is pretty uncommon in an older, small breed dog. So if you hear what you think is a gallop in an old small breed dog, it's probably a mid-systolic click. And typically when you hear a mid-systolic click, they will then later on develop a heart murmur. And then lastly, on auscultation, you can hear a variety of arrhythmias as well. So next diagnostic test that you could do is an ECG. And the ECG can be used to assess things like P wave height and width to look for atrial dilation, and QRS height and width to look for ventricular dilation. But those things are pretty insensitive in dogs when trying to evaluate valve disease to determine if they have enlargement and know what stage of disease they're in and if treatment's needed. So really the ECGs most helpful in assessing arrhythmias if present on exam. And so this ECG is showing some atrial premature complexes, which is probably the most common arrhythmia we'll see with valve disease. And so the atrial premature complexes can occur as atria enlarges or dilates. However, we can also see APCs in normal dogs or dogs without atrial dilation. And so looking at this ECG, you have an upright P wave. And then you have a P for every QRS, QRS for every P. So that means that there is an underlying normal sinus rhythm. And then you have these extra beats that are occurring early, but they still look upright and narrow like the normal sinus complexes. So they're coming from above the ventricles or coming from the atrium, and then they don't have a P wave. So these extra beats are atrial, just single atrial premature complexes. Another common arrhythmia, more so in larger dogs, but we can see it in some smaller dogs, is atrial fibrillation. And so in atrial fibrillation, there's essentially multiple reentrant circuits within the atria that results in a very fast and irregular heart rate. And on ECG, there's really 5 criteria for AFib, kind of 4 main ones, and then 1 minor one. So the first criteria is that there's no P waves. So if you look on this ECG, you might see, a little thing right here that you could think is a P wave, but then if you keep looking, there's no consistent and identifiable P waves. So no P waves. The second criteria is that it's irregularly irregular. So that means that the QRS complexes have no consistent timing. So there's a little bit farther apart, then they get closer, then farther apart, closer. So there's no rhyme or reason to when the next QRS complex will occur. The heart rate is fast. Typically in dogs, it will be over 200 when it is due to underlying structural heart disease. And then the QRS complexes are still upright and narrow. So that tells you that it's a supraventricular arrhythmia or coming from above the ventricles. There are some exceptions to that, but that's kind of outside the scope of this talk. And then the last criteria, kind of the least important criteria, is that you can see fib waves or fibrillation waves, which are basically little baseline undulations. And many times we don't see that in dogs. So if you don't see it, doesn't mean it's not atrial fibrillation. And I actually find the opposite, that sometimes they're overinterpreted. If you have a dog that's, shaking or shivering or even panting when you're doing an ECG, sometimes they can artificially cause some baseline motion. But sometimes you can see a little bit of baseline motion or fib waves. Next are ventricular premature complexes. We don't see these as commonly with valve disease as some other diseases like DCM, but they do occur occasionally. And so these ECGs are both, again, normal underlying sinus rhythm. You have an upright P wave, P for every QRS, QRS for every P. So this is a sinus rhythm. Then you have these extra early beats, but these beats are wide and bizarre compared to the normal sinus beats. So these are coming from the ventricle, and these are single ventricular premature complexes. And then hopefully we never see this, which is pretty uncommon in valve disease. This is actually, the specific example was from a boxer with ARVC. And so this is ventricular tachycardia. We can also see, I didn't include a slide, but we can also see other bradyarrhythmias like AV block, for example, in dogs with valve disease, but that it would not be due to the valve disease. So sometimes they can have concurrent aging disease of their conduction system versus the arrhythmias we just talked about occurred due to the disease itself. Next diagnostic test we'll go over is just thoracic radiographs. So simple radiographs are actually very helpful in valve disease for a number of reasons. First, it allows us to assess the cardiac silhouette for any enlargement, and that can help us know if treatment is needed, especially if they can't do other tests like an echo, which we all know there's plenty of people that can't do an echo, whether it's due to the cost or just availability. And second, thoracic radiographs are how we diagnose congestive heart failure. So on echo, I can certainly have concerns that the pet is in congestive heart failure, but I can't diagnose heart failure on an echo. It is a radiographic diagnosis. You have to actually see the pulmonary edema or congestive heart failure on the x-rays. And so on radiographs, there are really 3 main criteria that we look at for determining if a patient has congestive heart failure. So first is they have cardiomegaly or heart enlargement. Second, they will have pulmonary venous dissension. So if you look at the pulmonary veins and compare them to the arteries, the pulmonary veins should be bigger. And then lastly, they'll have pulmonary edema, which in dogs, thankfully, is typically a pretty predictable pattern. Starts perihilar to caudal dorsal, oftentimes starting or worse in the right caudal lung fields compared to the left. And so overall, dogs are much easier compared to cats, for example, and knowing if the pulmonary pattern is consistent with heart failure. Of course, they can't make life too easy, so there has to be some exceptions. And so some of those, if they have an acute chordae tendineae rupture, then sometimes the pulmonary pattern can be a little bit different. And they also may not have as severe cardiomegaly if they have a acute chordae tendineae rupture. So what happens when they rupture that chordae is it suddenly worsens the amount of mitral regurgitation. And so sometimes that then can cause them to go into congestive heart failure before their heart has really had time to dilate. And so that is one, fairly rare exception. And then another exception to at least the pulmonary venous distension is if they've gotten a furosemide injection. So if a patient presents with symptoms, you give a furosemide injection and then take radiographs like an hour later, that furosemide will kick in and causes their pulmonary veins to shrink down pretty quickly. So hopefully when you do the x-rays, you would know the timing and if they've gotten any furosemide. So here's an example of a radiograph, and the heart's actually fairly normal size. So if you do a vertebral heart score, it comes out around 9 or so. And we do know there's some breed variations, but then if you also just look at the heart itself, especially the caudal border of the cardiac silhouette, you can see it's nice and smooth. There's no real bulge or anything like that. And then you have this dog that does have some cardiomegaly. The pulmonary veins still look okay and the lungs look okay. On the lateral, I think it's always harder to interpret than the VD. I usually prefer to look at the lungs, but the lungs look good in this dog. And if you do the VHS, it comes out to be about 10.7 or so. And then if you follow, again, the caudal border of the heart, you can see where it then has this bulge right here, which is the left atrium. And so this is what some people call the backpack sign. So they think when the left atrium is enlarged, it looks like the heart has a little backpack on it. I don't know if anyone's ever heard that. And then here's a dog with congestive heart failure, severe cardiomegaly, and has pulmonary edema. Next, I'll just briefly touch on biomarkers, the main ones being NT-proBNP and cardiac troponin. And so just a reminder, the BNP is released in response to myocardial stretch, and then the troponin is released in response to myocardial injury. And so this illustration down here shows the contractile unit of the cardiomyocyte, and you can see there's 3 different troponins, C, T, and I. The one we're measuring is this one, the C, T, and I. And so overall, there have been so many studies on both of these biomarkers in regards to a lot of different clinical settings. I think every time I open a journal, there's a new article on some kind of biomarker. So it's been looked at in valve disease, DCM, CATS, in the presence or absence of congestive heart failure with arrhythmias, different systemic diseases. I could probably do a whole presentation itself on just biomarkers, which I can do next year unless it's going to bore everyone. But essentially, both of these biomarkers will increase with increasing disease severity. So they could be useful as a screening test. Personally, I think if your dog has a murmur, you're suspicious of valve disease. If you're trying to determine if the disease is severe or not, really radiographs I would prioritize over the biomarkers. I think the radiographs just give you more information. They can become a little bit more useful in the presence of symptoms. So with both of the biomarkers, it can be false positives and negatives. But if there are symptoms present, such as difficulty breathing, then the positive predictive value of the test increases. So if you're concerned about heart failure, then it's positive. It likely is heart failure. Of course, if you're concerned about heart failure in a dog, it's, again, probably better to just do radiographs because they're more easily diagnosable on radiographs. It's a totally different story for cats because the radiographs can look all over the place. So the biomarkers are, I think, more helpful in trying to weed that out. And then just to mention that neither one of these has been shown to be useful in monitoring the disease progression. So just because if you serially monitor the values, just because they're increasing doesn't mean the disease is getting worse. And just because their values are stable doesn't mean the disease is stable. And so there's been proven to be a high degree of weekly variability in dogs. So monitoring it serially is not really of much benefit. And so then lastly, we have echocardiogram, which is how we are obviously going to definitively diagnose valve disease. And so on the echo, we're looking for valvular thickening and regurgitation, determine which valves are leaking and how much. We can see if there's prolapse of the valve leaflets or ruptured chordae tendineae. We can assess chamber dilation and determine the need for medications. We can assess their heart function. Rarely in dogs with valve disease, we can see that they rupture their left atrium, and we can see evidence of that on the echo. If you remember back to school, probably when they have the chronic mitral regurgitation, that regurgitation kind of hits the same spot of the atrial wall over and over again, which can result in like a jet lesion you'll see on necropsy. But over time, that can cause endocardial splitting and can cause, really, it's a tear through the atrial wall. And when that happens, they then bleed out into their pericardial space. And so on the echo, what we see is we see pericardial effusion, and then we typically see a blood clot, a long blood clot within the pericardial space, and it kind of acts as a Band-Aid and covers that hole if the patient lives through it. Sometimes they can pass away suddenly when that happens. And then we can see pericardial or pleural effusions. Again, pericardial effusion for valve disease is typically due to ruptured left atrium. We don't typically see pericardial or pleural effusion due to heart failure in dogs. Again, there's exceptions, but not common. And then the echo allows us to assess for concurrent conditions such as pulmonary hypertension or any cardiac masses. Actually, I had a dog or a patient, it was a dog that presented a couple weeks ago to recheck its valve disease. It had early valve disease, and it had been a couple years since I saw it, so they'd been late for their recheck. But on the echo, to our surprise, the valve disease was actually very stable, but unfortunately, we saw a very large mass involving the interatrial septum, which we would not have known if we didn't do the echo. So sometimes there are surprises. So here's an image from echo. This is a left parasternal image. So this is the left atrium. This is the left ventricle. This is the mitral valve. And then all the bright kind of yellow, blue party colors is the mitral regurgitation. And then here is a right parasternal short axis image at the base of the heart. So in the middle is the aorta. You can kind of see the aortic valve, kind of looks like a Mercedes-Benz sign. And then this is the left atrium. And so typically the left atrial diameter and the aortic diameter should be about equal. And so both of these cases, you can see the left atrium is bigger than the aorta. So both of these cases had atrial dilation. And then this is that echo from that dog I just mentioned. So this is a right parasternal long axis 4-chamber view. So here is the left atrium, mitral valve, left ventricle, right atrium, tricuspid valve, right ventricle. And then this is that mass that is basically obliterating the entire interatrial septum, or the wall that normally separates the two atria. And just in case you're not sick of hearing me talk about Cavaliers, Texas A&M did recently do a large study looking at Cavaliers, and they basically did all these different tests we talked about in Cavaliers to see kind of what was useful and what was not. And so they did 226 Cavaliers, which just sounds like heaven to me. And then they looked at all these tests. And so what they found was that for physical exam, really the most consistent finding was just a heart murmur. And then with the heart murmurs, they did find that dogs in stage B1 had variable murmurs. So sometimes the dogs with stage B1 had a murmur as low as a grade 1, but some B1 dogs had a murmur up to a grade 6. And we'll go over the staging shortly, but B1, they had murmurs grade 1 to even as loud as a grade 6. Grade or stage B2 dogs, though, had typically murmurs that were grade 3 to 6, mostly 4 to 6. So that fits what I previously mentioned, that if it's a soft murmur, like a grade 1 to 2, it's usually mild disease. But if it's a loud murmur, it could be either. For ECGs, they found that the most common finding was, again, just APCs. And they did see that they happen in Cavaliers regardless of the stage of disease. So some dogs that occurred with atrial dilation, but there were dogs that had a normal atrial size and still had the APCs. They did not see any of the ECG criteria, so like P wave height, P wave width, QRS height, QRS width. None of those were accurate in predicting stage or disease severity. For echo, we'll talk about the criteria for different stages, but they found some dogs met one without meeting the other, which can complicate whether, knowing whether you want to start treatment or not. For the biomarkers, they found that they did increase with disease severity, but there was still some overlap. And then for radiographs, again, there was some overlap as well. So next we'll go over what the stages mean, and then how that treatment recommendations change depending on the stage. So originally in 2009, the ACVM came up with a consensus statement that came up with staging scheme for valve disease in dogs based on similar staging scheme in people. And so then more recently in 2019, they updated that consensus statement and revised the staging. So that's what we will go over today, is updated staging. And so the stages are divided into stage A, B1, B2, C, and D. So stage A dogs are just your at-risk breed. So they technically don't even have the disease yet. They're just a breed that we commonly see, which is mainly our Cavaliers. Stage B1 dogs are dogs that have valvular regurgitation, so they have disease, and then their heart chambers can be normal to mildly dilated. So really the update in the consensus was in regards to B1 and B2. So now a B1 dog can have mild dilation and still be classified as a B1. Stage B2, they have valvular regurgitation, and then they have enough chamber dilation that they meet the EPIC trial criteria, which we'll go over next. And then stage C is when they are or have been in congestive heart failure. So once they have an episode of congestive heart failure, even if it's controlled, they're always a stage C. And then stage D is refractory heart failure. So to be classified as a stage B2 on echo, these are the measurements that they must meet. The first is an LA to AO ratio on the right-sided short axis view in early diastole, greater than or equal to 1.6. And then the second measurement is a left ventricular internal diameter in diastole normalized to body weight over or greater or equal to 1.7. And so there is some controversy over these measurements, mainly the left ventricular measurement. So who knows, they may update this again in another couple of years, and then I'll give another CE talk on it. And so this is the LA to AO view. So that's the ratio of the left atrium, which is your orange line, compared to your aortic measurement, which is your blue line, and it should be equal to or greater than 1.6. And then this is the short axis apical view. So this is the left ventricle. And the second measurement is the internal diameter. So this diameter on the inside of the ventricle. And then we at end diastole, or what is the biggest, and we normalize it to the patient's body weight using a scaling exponent. And so those measurements are the cutoff for being a B2, and those measurements are based on a recent trial called the EPIC trial. And so this was a large multi-institutional study. It had 36 different hospitals participated in it, and they had a total of 360 dogs, which is a fairly good size study for veterinary medicine. And it took place over about 5 years. And so in order to be included in this study, they had to meet the echo measurements, so the left atrial measurement and the left ventricular measurement that I just mentioned. Plus they included vertebral heart score over 10.5, although they did find that that was the least important criteria, meaning that some dogs met that vertebral heart score criteria, but they didn't meet the echo criteria. And so if they met those criteria, the dogs were enrolled in the study and they were given either Pimo or a placebo. And they found that the dogs that got pimobendan had about 15 months longer until the time that they reached primary endpoint, which was either congestive heart failure or death. So again, there's some argument over this measurement right here. So we may change that definition in the future, and I'll keep you updated. And so if you don't have an echo, the updated consensus does have some guidelines for classifying as stage B2 based on just radiographs, which is great for, again, the patients or clients that can't get an echo. Then there are some recommendations just for radiographs. So the first criteria is if they don't have an echo, but on radiographs, the VHS vertebral heart score is over 11.5. Then you can classify it as a stage B2. Or if they have evidence of increasing cardiac enlargement on radiographs. So if you say you do initial radiographs, the vertebral heart score is 10.5, but then you recheck radiographs 6 months later and the heart has increased to a VHS of 11, the heart is increasing in size. So you can then classify it as a stage B1 if they're getting progressively larger. And then the last criteria is if you don't have the VHS or they don't meet the VHS, you can do it based on a VLAS over 3 or vertebral left atrial score over 3 on the radiographs. And so I think most people are familiar with vertebral heart score, so I'm not going to go over that. I think the vertebral left atrial score is a little bit newer, so I will go over that. And so the vertebral left atrial score or VLAS is an index of mainly just the left atrial enlargement. So vertebral heart score is really assessing the whole heart as a whole, versus this is more specific for looking at left atrial enlargement. And so you measure on the lateral image just like VHS, and you draw a line from the center of the most ventral aspect of the carina to the most caudal aspect of the left atrium where it intersects with the dorsal border of the caudal vena cava. And then you transpose that line to the cranial edge of the fourth intervertebral or vertebral body. And so if that measurement is over 3 on radiographs, then you could classify it as the stage B2. And then again, once they're in congestive heart failure on radiographs, that's a stage C. And then we'll talk about treatment, but the line between C and D is a little bit more blurred. So the stages are important to know because that's how we determine if treatment is needed or not, or recommended. And so first for stage A, again, these dogs technically don't even have the disease yet. They're just at risk of developing the disease. So no drug therapy is recommended and no dietary therapy is recommended. And it's just recommended really to monitor them for the development of a heart murmur at your annual or semi-annual exams. For at-risk breeds like Cavaliers, there are some breeding guidelines. Obviously, should not be bred if they have mitral regurgitation or a murmur. And there is some evidence that depending on the breeding scheme, you can reduce the prevalence of valve disease. Oops. And so in Denmark, they actually had came up with this mandatory breeding scheme where the dogs had to, which is in Cavaliers, the dogs had to be over 1.5 years of age before they were first examined. So they couldn't be bred before 1.5 years of age. And then they were examined and had to have auscultation and an echo. And then if they cleared on the first auscultation and echo at 1.5 years, then they could be used for breeding until they were 4 years of age. If they wanted to continue to be bred after 4 years of age, they had to be re-examined with, again, another auscultation and echo. And then they could be bred until they were 6. If they wanted to continue being bred after 6, which was mainly for male dogs at that point, then they had to be re-examined again. And by doing this, they actually had good results. And so they had a 73% decreased risk of having mitral regurgitation if both of the parents had been approved through this breeding scheme. Unfortunately, that kind of vigorous program is probably not going to be able to be implemented here. Cardiologists do screen different breeding dogs, but it's totally up to the owners and breeders if they want to do that. So moving on to stage B1. For dogs with stage B1, no drug therapy is recommended. And in the consensus, no dietary therapy was recommended either. Since the consensus statement came out, Purina did come out with their new CardioCare diet, which is targeted at dogs in B1 or B2, and they do have a couple studies looking at it. My current thought process is it's too new to really know if it helps. It's not going to hurt, but I don't know if it helps. So I've had some owners that want to try it. I'm happy to write them a prescription for it, but I'm not starting every dog that's a B1, not switching them to that diet. And then if they are B1, it's just recommended to monitor every 6 to 12 months for progression. And it is recommended to monitor more frequently, at least every 6 months if it is a larger breed dog, since they tend to progress more quickly. I always get the question, why don't we use Pimo in B1? And trust me, I absolutely love pimobendan, but short story is we just don't have enough information yet. Maybe one day in the future, we will start recommending it in B1, but right now we do not. And the longer study is just that so far there have really been no prospective studies that have shown a benefit to using it in B1. And really the only studies that have been done have shown some potential negative effects, not to mention it's expensive, so it's not going to help. Then why have them, spend lots of money on a medication? And so this prospective study was done on research dogs, research beagles with naturally occurring valve disease, and they were stage B1. And they either got pimobendan or benazepril. And it was a fairly long study, over 512 days. And they found that the mitral regurgitation actually worsened in the Pimo group, but did not in the benazepril group. Again, it's a pretty low number of dogs, but still. Then after the end of the study, actually euthanized the dogs and did necropsy, and they found the histopath changes were also worse in the Pimo group compared to the benazepril group. And some of the dogs in the Pimo group had chordae tendineae that were ruptured versus none of them in the benazepril group did. And then there's been a few case reports as well of pimobendan being used in early disease. And so this was a case report of 2 different dogs, a German Shepherd and a Poodle, that had been on pimobendan for a while. And they found on echo that they had left ventricular hypertrophy or thickening, diastolic dysfunction, and mitral regurgitation. So they kind of looked like an HCM or hypertrophic cardiomyopathy phenotype that we would see in a cat. And so they stopped the pimobendan in these dogs and rechecked them. And in both the dogs, the mitral regurgitation decreased. One of the dogs, the mitral regurgitation actually completely went away. So his heart murmur disappeared. And then their myocardial hypertrophy and diastolic dysfunction both went away. So again, if it's not proven to help and may hurt and is definitely expensive, then currently we don't recommend it. So moving on to B2. B2, pimobendan is definitely recommended. So now that was another update in the consensus was that at B2, the use of pimobendan is recommended. The use of ACE inhibitors still in B2 is still controversial. So that was still unable to, they were unable to reach a consensus on the use of ACE inhibitors. So some cardiologists recommend, some don't. And that's really just because there's been a couple of studies that showed conflicting evidence. One showed no improvement or no benefit in delaying the time until onset of heart failure. And then the other study showed that it did prolong the time until they went to heart failure by, I think it's about 3 to 5 months. And so there's also some people that think that the dose they used in those studies may have been too low, and that's why they didn't show any improvement. But regardless, you could use it or not use it. Depends on probably where you're trained, which one you do. So I usually use it in moderate to severe cases. If they're very mild, I may not use it. And then definitely if they have significant acytemia or some contraindication to using ACE inhibitor, then we won't use it. Other drugs like spironolactone are not recommended for routine use in B2, which I'll go over a little bit more on the next slide. And then other drugs like beta blockers, that kind of thing, aren't recommended in B2. And so touching base on spironolactone some more. So we don't really use spironolactone for its diuretic properties, although I think that's what most people were probably taught in veterinary school. The main reason we use it is really for its aldosterone antagonism, which should help kind of counteract the RAS system that is overactivated when they get to the point of being a B2 or C dog. And so in B2, the reason we don't recommend it is that there just hasn't been evidence yet that it helps. So again, if there's no evidence it helps, then why use it? And so far, there's really only been one study done, though, is a pilot study in B2 dogs. And they did see some changes in the spironolactone group compared to the placebo group, but nothing reached significance, likely due to type 2 error, meaning that the sample, they just had too few dogs, the low sample size. And so hopefully there'll be a larger study in the future. Personally, I don't use it in most B2 dogs, but occasionally if I have a dog that's just on the brink of heart failure, I have some patients that you're just waiting any second now they're going to go into heart failure. I've used it, but for most B2 dogs, we don't use spironolactone. So the next stage C, so once they go into congestive heart failure, so if they present in respiratory distress or tachypneic in the acute setting, we treat with furosemide, that's the mainstay treatment. And so if they're coming in respiratory distress, typically kind of two different treatments protocols you can use. One is just giving a 2 mg per kg bolus IV injection, or you can give IM to start until you can get a catheter in. And you can repeat that dose up to 8 mg per kg over a 4-hour period. So typically I'll give like a 2 mg per kg injection if they're just mildly tachypneic. And then depending on how quickly they improve, you can do it every 6-8 hours, depending on how they're responding. Alternatively, you can just do a CRI at about a 0.5 to 1 mg per kg per hour. And so sometimes if they're not responding to bolus injections, then they'll switch to a CRI, or if they come to begin with, they come through the ER and they're just very severely dyspneic to begin with, we'll go ahead and start a CRI from the get-go. And then oxygen supplementation is helpful. Pimobendan is recommended in the acute setting. It does take effect pretty quickly within 30 minutes to an hour, so it is helpful. Obviously, if they're stable enough to get a pill. And then sedation. So something like butorphanol can go a long way, especially if it is a very stressed out dog, similar to what we see in our cats. If they have any effusions present, then we do a centesis. Again, not very common in our dogs with valve disease. But if they did happen to have effusion, we can remove that. And then things like nitroglycerin or nitroprusside can be added for life-threatening pulmonary edema that's not responding to just furosemide alone. Nitroglycerin or nitroprusside is definitely more effective than nitroglycerin, but it's pretty expensive, so not probably as routinely available. Nitroglycerin is just a topical you put on the ear. If they are hypotensive, then we can add a dobutamine CRI. And then in the worst case scenario, you can do mechanical ventilation until you can get their heart failure under control. Typically, these don't really have the best end results, but I have seen some, especially in like an acute chordae rupture or something like that. I have had patients that have been on mechanical ventilation and recovered. And then chronic treatment. So once they're stabilized after the acute setting and then go home, or if they're only mildly affected to begin with, you can just start them on chronic oral treatment. So again, furosemide is the mainstay. And then ACE inhibitor is recommended. So especially when you get to this point, you likely have RAS overactivation. And then by giving furosemide, you're going to stimulate the RAS system even more. Pimobendan for sure is recommended in congestive heart failure. And it's actually FDA approved for treatment of heart failure in dogs with valve disease. And then spironolactone as well. And I added an asterisk to that because, again, I think historically people have been adding it on more as an adjunctive treatment once they are becoming more refractory to furosemide, but it is recommended from the get-go. Once they're in congestive heart failure from the very beginning, recommended to add on spironolactone. Again, not due to its diuretic properties, but due to its aldosterone antagonism. And then additional treatments, antiarrhythmics, a variety of them can be used depending on the situation. So if they're in atrial fibrillation, we'll use things like digoxin and or diltiazem. We typically don't use beta blockers as much. If they have ventricular arrhythmias, we're usually using sodium or potassium channel blockers. If they're coughing just from their heart enlargement, then we definitely add in cough suppressants and sometimes bronchodilators as well. So again, just to touch base on spironolactone again, it is recommended in stage C from the beginning, so not just in refractory cases. And there's been a couple studies showing that dogs with congestive heart failure due to valve disease had a prolonged survival with spironolactone. So the first study was called the BEST study. All these studies have fancy names. And it looked at 569 dogs in heart failure, and they used a combination of spironolactone and benazepril. And they found that the combo spironolactone and benazepril was superior to benazepril alone. And then the second study had a little over 200 dogs, and they found that the spironolactone had a prolonged survival compared to treatment without spironolactone. And so I'm sure you all have seen Ceva's drug Cardalis, so it is a combination ACE inhibitor and spironolactone. So it is available. I do want to note though that if you start Cardalis, they don't need another ACE inhibitor like enalapril. Sometimes I'll see that they're on chemobetadine and enalapril in B2, and then they go into heart failure, the Cardalis is added, but you don't want to double up on your ACE inhibitors. So you can use this spironolactone and benazepril, or you can use them separately, generic separately. So besides medications, the consensus statement also recommends certain dietary changes. First, they recommend ensuring there's adequate caloric intake. As I mentioned earlier, cardiac cachexia is a negative prognostic indicator. And there's something that's well described in people called the obesity paradox, whereas obesity predisposes people to heart disease, and not as much necessary for our dogs, but then once they have heart disease, if it's advanced enough, the patients that are overweight actually tend to fare better than patients that are underweight or that start to lose weight. And similar thing is seen in our patients. So the dogs that maintain their weight have a better prognosis than dogs that lose their weight. So making sure they're eating well, and definitely don't shy away from giving things like Entice if they have a decreased appetite, or if they start becoming picky. A lot of dogs will get dysrexia, where they'll start liking a food, and then after a couple of weeks then they like a different food, and that's pretty common in advanced heart disease. Secondly, as part of the daily caloric intake, you want to make sure that they have adequate amount of high quality protein. And so typically we avoid things like low protein diets for renal disease unless they have severe CKD. At that point, then, sometimes you have to pick the lesser of two evils. And then lastly, moderate sodium restriction is also recommended. So typically we say less than 80 milligrams of sodium per 100 kcals of food. And then there are some cardiac specific diets out there, which I'm sure you're familiar with, but really there's lots of diets out there that fit the cardio-friendly profile. So even diets like Purina JM, for example, are pretty good and have the added benefits of having omega-3s added to them. Other dietary changes that were mentioned in the consensus were supplementing potassium if hypokalemia is present, which can occur with furosemide. Typically in dogs, it doesn't tend to be as big of a problem as it does in cats, but still we obviously monitor those values. Some people add in magnesium. Theoretically, low magnesium levels can predispose to ventricular arrhythmias. So especially in some dogs, if they have ventricular arrhythmias, and supplementing magnesium might be helpful. Omega-3 fatty acids can help both with the arrhythmias and can also help with the cardiac cachexia. And then another supplement that was mentioned was coenzyme Q10. Again, it's not definitively proven to help, but may. And then the published dose for coenzyme Q10 is just all over the place. So it's a little bit harder to know what to recommend. So moving on to stage D, as I mentioned before in the staging, the distinction between C and D isn't necessarily clear cut. So some people may call something a stage D before another, but overall they're a stage D once they're on the standard doses of medications and they still are having symptoms or they're having repeated episodes of congestive heart failure. So some of the things that were mentioned in stage D, everyone agreed that after load reduction, it could be helpful. So if they have a blood pressure over 150, then adding something like amlodipine to decrease the afterload. And then no consensus was reached on the other recommendations, but other things that people mentioned that they do. A lot of cardiologists will increase pimobendan to 3 times a day. And some also increase even the dose quite a bit. Really depends, I guess, on where people were trained. Once they're getting on the higher dose of furosemide and not responding anymore, then we switch to torsemide. The torsemide is a loop diuretic like furosemide, but it's about 10 to 20 times more potent, and it lasts longer as well. And so most people do switch to it when they're becoming refractory to furosemide. Some people even start using torsemide even earlier on in the disease process. The downsides to it is more likely to cause acute kidney injury and things like hypokalemia. And so typically if they're responding to just normal furosemide doses, I start with that. But definitely if they're not responding or have had repeat episodes, and starting torsemide. Important thing is just to start low and keep an eye on blood work. Hydrochlorothiazide is another diuretic that acts on the distal convoluted tubule and can be added on. It can cause hypercalcemia and AKI and hypokalemia. So typically I would not use this with torsemide because the two combined can cause the potassium to drop quite a bit, but that is another option. Some cardiologists will add in sildenafil even in the absence of pulmonary hypertension, depending on the symptoms that the patient's exhibiting. Important just to note, though, that the sildenafil, depending on the situation, can worsen left-sided heart failure. So it does have to be used in caution, with caution. And then costopresins are definitely used and bronchodilators for their cough just from the cardiomegaly itself. And then lastly, besides treatment, it is recommended to really in all stages to start having the owners monitor the resting respiratory rate. So there's, I think, a couple different apps, but this is the Cardallis app that people can download. And typically we say if the respiratory rate increases over 30 to 40 when they're sleeping, that is a sensitive indicator that they could be going into congestive heart failure. And so usually in B1 dogs, I'll tell them to start monitoring it like once or twice a week just to get a baseline for them, what's normal. And then as they advance, we'll monitor it more frequently. So that concludes probably what most of you will be doing every day, or at least what I will definitely be doing every day. But then I'm going to review some more advanced options for the patients or clients, rather, that truly want to do everything and sometimes have no financial constraints or anything like that. So one of the advanced options that's been more recently described is a procedure called a left atrial decompression. And so this is a minimally invasive creation of an atrial septal defect. So it basically helps offload the left atrium to decrease the pressure within the left atrium. And it's performed under general anesthesia, and they use both transesophageal echo to guide it and fluoroscopic guidance. And so currently at NBS, at our hospital, we don't have either fluoroscopy or transesophageal echo, so we will not be doing this procedure. And so it's really mainly done at universities. And so what happens is they get percutaneous access, and then they do a transseptal puncture coming from the right side across the inner atrial septum. And then they either use a balloon to dilate and make the hole bigger, or they can put a stent to keep the hole bigger between the two atria. And the really main study or case report, rather, that's retrospective study that has been reported was recently over 2018 and 2019. They did 17 dogs, and the median survival following it is really highly variable. So some as short as 0. So they did have dogs that developed complications immediately after the procedure, but then they had some that fared pretty well after. So again, nothing that's routinely done, but it seems that certain universities, they are starting to do it more. Another option, more advanced option, is medical therapy with Entresto. I mentioned this last time I gave the CE. And so it's really only considered an advanced option because of its cost. And depending on the size of the patient, it could be anywhere from $300 to $600 a month or more. So most people aren't going to necessarily go for that. And so Entresto would be used in place of an ACE inhibitor. And it's made up of two different drugs. First is valsartan, which is an angiotensin receptor blocker. So it blocks this part of this pathway here. And then the second drug is sacubitril, which is a naltrexone inhibitor, which would be blocking right here. And so naltrexone is what normally degrades your natriuretic peptides, your BNP. And so if you stop naltrexone, then you have decreased degradation of BNP, which is your natural natriuretic peptide that causes diuresis and vasodilation. And so far, there have really been only a couple studies, again, mainly because of the cost of the drug. So this first was one of the first studies that done was really a pilot study. So just trying to assess the safety of it. And they had 13 dogs that were B2. And it was a fairly short study, but again, they were just trying to see if it was safe, if it affected the blood work at all compared to the ACE inhibitor. So again, this is used in replace of ACE inhibitor. So they stop the ACE inhibitor, there's a 2-week washout, and then they start the Entresto. They basically found in this study that there were no adverse effects. So the dogs did tolerate it well. And personally, I've had a few patients on it, mainly owners that were human cardiologists. I think one, because they probably didn't have as many financial constraints. And two, I think they saw the benefits in their patients. So it made sense for them to use it. But it hasn't really been studied very much, again, mainly because of the cost of the drug. Eventually, it hopefully will go generic. The next advanced option would be surgical mitral valve repair. And so the mitral or valve disease is a leaking problem. So you have leaking of the valve. So really the only way to fix it is to actually fix the leak, which is what they do with mitral valve repair. And so ideally, they do it in dogs that are less than 13, but they will do it in older dogs. And then it's done in stage B2, C, or D. There is an increased risk of complications the later on in the disease you do it. And so for mitral valve repair, they're placed on cardiac bypass. So it's an open heart surgery. And then during the surgery, they pre-place some artificial chordae to kind of know where they're going to go. And then they use this PTFE suture to place a permanent chordae between the valve leaflet and the papillary muscles. And they typically place a total of 4 to 6 cords. So this image has 4, 1, 2, 3, 4 cords that they've placed. And then they also do an annuloplasty to actually tighten the mitral valve ring as well, which helps decrease the amount of regurgitation. And they use the same suture. And after they do that, they tighten the cords. And when they do this procedure, they are able to significantly decrease the mitral regurgitation. In some cases, they actually completely eliminate the regurgitation altogether. And they report, I've never seen the procedure, but afterwards their heart shrinks pretty considerably, pretty quickly. So then the recovery after the surgery is usually kind of the most challenging part. So they do well during the surgery, and then after the surgery, there are some complications that can develop. One of the biggest complications is thromboembolic disease, thromboembolisms, which unfortunately our cavaliers are predisposed to. And so because of that, they're on anticoagulants and antiplatelets for a while after surgery, and they're typically hospitalized for at least a week or longer if they do end up experiencing complications. And then the long-term recovery, or the recovery can be a little bit longer after that. They have, modified activity for quite a while after surgery. But the dogs can do very well with the surgery, and they can come off all or at least some of the heart medications, sometimes all of them. And so it is a great option if it's available, if it's something that people can do. And so the cost, there are 2 really main hospitals that do the surgery right now, Royal Veterinary College in London, and then Jasmine Clinic, which is in Japan. And so the cost is pretty similar between the 2. Royal Veterinary College is about $21K, Jasmine's about $18K, but then different things are covered within that cost estimate. And owners get a very detailed estimate. If they're interested in surgery, they send them a very detailed estimate of what's included in the cost and all of that. And the cost will vary somewhat too, depending on the exchange rate. And I'm told right now I have several clients, I have 2 trying to go to Japan, and I have 4 trying to go to Royal Veterinary College. And so I'm told that the exchange rate is better right now than it has been, but of course that could always change. And they do require a deposit that's not refundable to secure the surgery date. And then they get another deposit once they are hospitalized. And then, like I said, those costs are typically the surgery doesn't always include the cost of other things. So neither of those places include the cost of flights for the owners, hospital or hotel for the owners when they're staying there for the week, plus a lot of the pre-op and post-op diagnostics that they require aren't included. Overall, they've had pretty good results, though. Dr. Uechi is the doctor in Japan who's been doing the procedure. He's been doing it the longest. And so far, the most recent statistic was that he had done about 1,000 dogs, and he has about a 98% survival perioperatively. So most of the dogs survive the surgery just fine. And then about a 92% discharge rate. So the difference between those two are dogs that develop post-op complications and then pass away. Dr. Brockman is the surgeon who does it at Royal Veterinary College, and he hasn't been doing it as long. So as of May 2019 was the latest statistic I found. He had done about 75 dogs, and he reports about a 90% success rate. It didn't specify whether that was survival perioperative or discharge rate. So here's the Jasmine Hospital. This is the Royal Veterinary College team, and this is also a hospital in France that the Japan team has gone to before. And so then the last advanced option, which is what I'm most excited about because I think it would be the most readily accessible option for owners, is called Transcatheter Edge-to-Edge Mitral Valve Repair, or TEER for short. And so this was started at and is currently being done at Colorado State University just within the last couple of years. And what's even more exciting is that they have plans to go and train other universities so that it's not just one place that offers this. And recently I spoke with a resident at University of Illinois, and they actually have their first surgery soon. So the Colorado team is actually going to Illinois and helping them with their first surgery. And then they're already starting to schedule other dogs for the surgery. So definitely for us in Nashville, I think it's way more feasible for someone to drive to University of Illinois than fly across the seas to Japan or something like that. And so for this, the TEER, they use what's called a V clamp, which I have a picture of on the next slide. And it's done under general anesthesia, and they use fluoroscopy and transesophageal echo guidance. And so unlike mitral valve repair, it's done on a beating heart. So they don't have to stop the heart or use bypass or anything like that. And it's a quote unquote hybrid procedure. So the surgeon is doing the approach and controlling the device, while the cardiologists are doing the transesophageal to help guide it and make sure it's placed properly. And so essentially they make a very tiny thoracotomy, and then they deploy the device transapically. So they actually go through the apex of the left ventricle, and then they place this clamp on the mitral valve leaflets to decrease the amount of regurgitation. So the difference is this is not repairing the mitral valve, so it's not going to have as great of a success rate or decrease the mitral regurgitation as much as the mitral valve repair will. But the hope is that it decreases the mitral regurgitation enough that helps prolong their survival. And it's a lot less invasive. They have an easier recovery. Typically the next day they're up and walking around from surgery. And then they typically stay, they go like on Monday, and they typically do stay the week, and then they recheck a month after, and then every 3 months for about a year. And then depending on how they look after that. And so the procedure itself is not quite as expensive. At our recent ACVM, they told us it was about $12,000, I believe, which sounds similar to $18,000 for Japan. But then if you remember that Japan also, then they have to, on top of that, pay for flights and hotel and things like that. This is definitely a less expensive option. And so unfortunately, there are only very specific cases that would be candidates for this procedure. And so first, they're looking at the severity of the mitral regurgitation. So they have to be a B2 or a C dog. And then it really depends on the specific anatomy of the mitral valve as well. So things like mitral valve prolapse are harder to do this procedure. The size of the mitral valve annulus also is a factor, which unfortunately a lot of Cavaliers, their mitral annulus is just so dilated that they can't have this because they only have certain sizes of the device, which I'll show you on the next slide. And then again, because they have a limited number of device sizes, the body weight of the patients is limited to dogs between 4 and 15 kilograms. So subset of dogs. And then they have to not have any other significant non-cardiac disease. So it's definitely something that's available. And I know we're gonna have people that are interested. And so if they're interested, the first thing is to kind of assess if they would even be considered a candidate, and then go from there. And I believe in June, at that point, Colorado had done about 28 dogs by that point. And so this is what the clamp looks like. So you can see the delivery device is coming in here. So this would be coming up through the left ventricle. And then it kind of has 4 arms. So kind of 2 below the valve leaflet. So one's here, and then one arm is here, one arm is here. And then they basically clamp down on the valve. And then that device just stays there. And so it's pretty cool new device that hopefully will be promising and will give us a better option than just medical therapy alone, because there's only so much we can do with medications, and we need something else to help all these dogs, not just the Cavaliers, but other dogs as well. And so with that, I think that is all I have. So thank you for tolerating all my dog pictures. And I'm happy to answer any questions. I do want to mention that in order to get your CE certificate, please send an email to this email right here. It's certificates@nashvillevetspecialist.com. Sorry if that's hard to see. And then please, when you send your email, put your name, your license number, and your state of licensure on the email so that they can get you your certificates. And with that, I'll take any questions. Feel free to speak up, or you can also put it in the chat. Thought I heard something, but I don't hear it anymore. Oh, there's a couple chats. Adrian, our lovely IT person who's amazing, put in the chat for the certificate. So he added the email and then what to include in your email. So if you can look in the chat real quick, that will tell you what to, where to email and then what to add to the email so that you get your certificate. Definitely deserve your certificate after being bombarded with all my dog pictures.
I got a question.
Yeah.
What's sort of the difference between some of the ACE inhibitors? Like I see some cardiologists that like enalapril over the benazepril, and I just wanted to see what your opinion was on those.
Yeah, there's really not a lot of difference. So the enalapril is excreted renally and hepatically versus the benazepril is more hepatically. So some people think the benazepril is more kind of sparing on the kidneys, but that's actually never been researched or proven. So I use them interchangeably. So I typically just, I think use enalapril just because that's what I'm used to. But if it's on benazepril, I don't switch them off it or anything. Benazepril is also usually dosed more once a day versus enalapril is twice a day. So like cats, I might use more benazepril because it's only once a day. But dogs are usually on twice a day medications anyway, so I don't think it's a problem giving their enalapril twice a day.
Thank you.
Yeah.
Sorry, my kid was coming in and giving me a unicorn.
That's okay.
So.
Any other questions? Okay, well, I think I will end the Zoom and hope everyone has a good night.